Okay, in this episode we continue our discussion of non-diarrheal GI symptoms in traveler with going through some very high-yield differential diagnosis briefly. In the episode dedicated to algorithmic approach to non-diarrheal GI symptoms in traveler, we had several cases that would discuss their management and differentials. However, let me just briefly go through some of those important cases as differential diagnosis. So first, what are the differential diagnosis of a traveler with fever and abdominal pain? Pay attention to the fact that if you are just set to diagnose abdominal pain and right upper quadrant pain is not specified, you are most likely dealing with enteric fever. However, if it is specifically mentioned that the patient has fever and right upper quadrant pain, especially with malaise, you are dealing most likely with amoebic or pyogenic liver abscess. However, if a patient with fever, right upper quadrant pain has been traveling to ship-rearing areas, what are the differentials? If you remember, the differentials would be liver fluke if the patient has eosinophilia or especially exposure to aquatic plants such as watergrass or freshwater fish. And the differential or the diagnosis will be echinococcosis if the patient has exposure with canine and ship raising in high altitude area. If anything, please review the management and differentiation of amoebic versus pyogenic liver abscess. Now, in this episode, we would like to discuss the differentials just briefly for a traveler with jaundice and organomegaly. Now, what are the 5 important differential diagnoses in a traveler with jaundice? Please always remember severe malaria, dengue, yellow fever, leptospirosis, and acute hepatitis are the top of the list of differentials in traveler with jaundice. Now, first case, you have a traveler with jaundice, anemia, and episodic fever. What is the best test for the diagnosis in this patient? Thin and thick blood smear for diagnosis of malaria. This is most likely a case of severe malaria because only severe malaria will manifest with jaundice due to hemolytic anemia. Next case, you have a traveler with jaundice, fever, hemorrhagic complications, and low platelet. What is the diagnosis? Remember, presence of fever, hemorrhage, plasma leak, and low platelet indicates diagnosis of dengue. Now, next case is a patient with jaundice, history of travel, especially to Far East, and now complains of retroorbital pain and photophobia. What is the diagnosis of this case? This is yellow fever. And finally, you have a traveler who has been exposed possibly to a flood or severe rainfall and now complains of not only jaundice and fever but myalgia and especially conjunctivitis. The question is, what is the diagnosis? That this is leptospirosis. Now, don't forget a patient with jaundice, history of travel, with malaise, especially if unvaccinated, would also have another diagnosis, which is acute hepatitis. And again, don't forget hepatitis B with its specific risk factors among male homosexuals and people who has received transfusion products before the screening was performed, or a patient with fecal oral exposure for hepatitis A and E. Okay, let's move on to patients with organomegaly. When it comes to organomegaly in travelers, I would like you to always differentiate two possible scenarios. One is those with both hepatomegaly and splenomegaly versus those who only have hepatomegaly. So let's start with those with splenomegaly, usually more significant, but also accompanied with hepatomegaly. What are the differential diagnoses? The differential diagnosis in traveler with hepatosplenomegaly includes again malaria, schistosoma mansoni, and visceral leishmaniasis. Now, in traveler with hepatosplenomegaly who gives a history of swimming or bathing and washing clothes, in a return traveler who now has hemoptysis and again hepatosplenomegaly, what tests should be performed and what's the management? Well, if this patient does not have any risk factor for cirrhosis such as alcoholism, an important differential given the travel history will be schistosoma mansoni or blood fluke. Just remember that the larval form called Sarkaria enters the skin while the adult form stays within the hepatic vessels, causing portal hypertension. Diagnosis is made by a stool for ova and parasite that shows eggs with lateral spine in the case of schistosoma mansoni, and treatment is praziquantel. Another important question is a patient with history of travel to certain endemic regions in tropics who now has splenomegaly, more significant than hepatomegaly, but also has lymphadenopathy, cytopenia, and hyperpigmentation. What is the diagnosis? This is the visceral leishmaniasis. The hyperpigmentation is black fever or kala azar, and remember, it is an AIDS-defining illness. And finally, we have a traveler with hepatomegaly only. What are the differential diagnoses? Always remember Entamoeba histolytica, Fasciola species, and Echinococcus. Again, how do we differentiate Fasciola? If a patient with a history of travel, especially to sheep raising areas, has eosinophilia with hepatomegaly but without splenomegaly, this is Fasciola. Thanks. This finishes our brief review of non-diarrheal GI symptoms with their differential diagnosis in traveler with either fever and abdominal pain or right upper quadrant pain or jaundice and organomegaly.